Hello, everyone, and welcome. My name is Hassan Taslimi, and this is going to be a case presentation of a case report that I've done of a case of Amyand hernia. So, first, let's start off with the definition of what an Amyand hernia is. So, an Amyand hernia is defined as a hernia that contains the appendix within the inguinal sac. And the clinical importance of this and clinical significance of this is that it is very rare. It is less than 1% of all of inguinal hernias, and also less than 0.1% of all hernias are considered Amyand hernias that have an inflamed appendix within it. So most of the times it's diagnosed intraoperatively, and it's rarely found preoperatively by imaging such as ultrasound. And surgical management depends on the degree of inflammation within the appendix, whether it's not like varying from not inflamed to inflamed and ruptured and with signs of peritonitis. This is the first paper of an Amyand hernia. It was named after the surgeon Amyand in 1735, and this is his original paper where he found incidentally on a hernia on a child boy 11 years old, and he found the appendix to be within the sac, so he named this case after his name. So for our case, the presenting complaint of the patient was a 53-year-old male who presented to the emergency department with severe pain and swelling in the right inguinal region. And this inguinal hernia he had for 2.5 years, and it was reducible and it was asymptomatic, but the patient declined elective surgery for it until it became obstructed now, and the patient presented with a day of nausea, vomiting, fever. So like very classical condition of intestinal obstruction, but also with the fever, there was some suspicion of some inflammatory process or some infectious process. So after this became irreducible, the patient presented to the ER, and he has a past medical history of hypertension, and the patient is also an active smoker. On physical examination, there was a right inguinal swelling that was tense, irreducible, and tender, very classic of an obstructed hernia, and the abdomen was distended with generalized tenderness. PR examination was normal, empty rectum, and the patient was hemodynamically stable other than the fever. Other than being febrile, he was not hemodynamically stable. Laboratory studies showed elevated WBC count with a left shift, neutrophilic shift. Hemoglobin was elevated, CRP was also elevated, and serum creatinine was also elevated, but these weren't in much. There wasn't much elevation of these, so possible explanation for these was because of the dehydration, and the hemoglobin was because of his smoking history. Other tests were within normal limits. Other relevant tests such as LFT, RFT, other than the creatinine, were within normal limits. Abdominal X-ray showed that there was multiple air fluid levels, and there was small bowel dilatation and signs of intestinal obstruction. Abdominal ultrasound showed the non-compressible bowel structure that is very classical and very typical of an appendix, of an inflamed appendix. So in this case, there was a high suspicion of an Amyand being just by imaging modality, just by ultrasound. This is the X-ray of the patient on admission. So as you can see here, there are multiple air fluid levels suggesting intestinal obstruction. And moving on. The primary management of this patient, he was given IV fluids and started on broad spectrum antibiotics, ceftriaxone and metronidazole, to cover for anaerobic bacteria mostly. Analgesia was administered, and surgical intervention was planned a few hours after the presentation to the ER. Diagnostic laparoscopy was performed, and I would explain why such modality was done, diagnostic laparoscopy, and instead of doing an open hernial repair, which is how usually hernial repairs are done, an open approach. So intraoperatively, there were it confirmed intraoperatively by laparoscopic imaging that it was a right indirect amyand hernia, and treatment was done when the hernial repair was hernia was fixed, and the appendix was removed, and there was no mesh placement, which is also an important part of this treatment modality because it's somewhat controversial why you would go for without mesh placement in such a case. So this is intraoperative findings. As you can see here, this is the hernial defect, and there is a large defect, and so much of the small bowel is protruding through it. And after reduction of the small bowel, the appendix was found to be here, as you can see here on the right picture. The appendix was found to be here, and it was very query as if it's inflamed or not. So it's a somewhat difficult, and you have to have an on-spot decision making whether to keep the appendix or not to keep the appendix. This is the hernial defect after the repair. As you can see here, this large hernial defect, and there was no mesh placed upon it. So post-operatively went on very smoothly as the patient recovered very well. By the next day, he was afebrile, and the abdomen was soft and non-tender, and all of the laboratory values were normalized, and the patient was discharged in a good condition. This is the Lawsonov and Basson criteria for Amyand hernias. It was done in 2008, but it's still used to this day. And it specifies different types of Amyand hernias. So the most common one is the type 1 Amyand hernia, which you would find a normal appendix, which, as I said, it's mostly an incidental finding on a hernial repair, and where you would have hernial reduction and then a mesh placement were to be done, and appendectomy is optional but usually not done. However, in our case, we treated according to a type 2 Amyand hernia where an inflamed appendix was very suspected, and there was no signs of peritonitis. So appendectomy was done, and that's why there was no hernial repair, no mesh placement, sorry. So some question marks of such case, why such treatment modality was done, as why the surgeon went on to do laparoscopic approach instead of a hernial instead of an open approach in the hernial repair, because there was high suspicion that this could be, and this is a very high suspicion of possibility of Amyand hernia, and with the possibility of an inflamed appendix and the possibility of having gangrenous bowel present in the patient. The surgeon opted to do a laparoscopic approach to first confirm the bowel viability and to see if there is any gangrenous bowel that needs resection. And there was a very high possibility of appendicitis because of the borderline findings of the CBC, and because of the fever getting so early in that is not typical in intestinal obstruction, and the surgeon's preference to do appendectomies laparoscopically. The appendix did not appear grossly inflamed on laparoscopy. That's why I said it's somewhat query that the appendix didn't appear very obviously to be inflamed. But as I said, there was very high suspicion, and it couldn't be ruled out and couldn't be kept in to prevent any further complications that the patient might suffer of. So that's why the treatment was done according to a type 2 Amyand hernia with an appendectomy and no mesh placement after it. And that's it. So thank you very much for tuning in.